So this is going to be a question and answer panel with 3 trainees. Thank you so much for giving up your time to join us today. And what we're going to do is ask some questions about careers in paediatrics. So if anyone has any questions that they'd like to ask as well, please feel free to drop a question in the chat, and we'll see if we can answer them all at the same time as well. So first, I'd just like to ask James, Monica, and Laura, who to just introduce themselves and tell us a bit about your job role at the moment and why you were interested in becoming a paediatrician in the first place. So shall we start with Laura? Is that okay? I think we've just lost James for a bit.
So hi, I'm Laura. I'm currently ST3 in neonates in Sheffield. So I'm in my last role before I move up to registrar level. Why I became interested in paediatrics? Well, first of all, you get to play with really cute babies, which is always nice, and also cute children. But also you get such a variety. You see all aspects of medicine. You're not just limited to seeing one thing. But then you have the option to specialize into one thing as well. So it gives you so much flexibility, and it's just a really fun career.
Wonderful, thank you, Laura. Monica, would you like to go next?
Yeah, hi everyone. My name is Monica. I work as a community child health grid trainee. So I'm sub-specializing. I'm doing my level 3 training in community child health in West Yorkshire. I'm SD7, so nearly done. Yay. And I think the main reason why I wanted to do pediatrics is because I think there's a real possibility for us to make a difference for a group of people who are very vulnerable potentially, and especially in community. I see this a lot with safeguarding work, looked after children. I think I just found my place.
Oh, oh, we've got James back. Vicky, you've got quite a lot of background noise.
Have I? I'm so sorry, because I'm actually at the studio right now, so it's just difficult finding a place, actually. Is that...
No problem. Yeah, that's better. Would you like to carry on?
Yeah, sorry, have we...
Well, if James is back,
sorry,
James,
I don't know what happened
me?
there.
Sorry,
everything died.
That's okay, don't worry. It tends to happen on the internet, unfortunately. We were just saying, if you could possibly introduce yourself, tell us a bit about your job at the moment and why you chose to become a paediatrician. That would be amazing.
Me. So I'm James Dearden. I'm a paediatric ST7. Yeah. So I'm just coming towards the end of my training. And I'm a trainee down in Southwest Peninsula regions in Devon and Cornwall. I'm currently doing a 12-month block on paediatric intensive care unit in Bristol Children's Hospital. I've always enjoyed working with children throughout my life, I suppose. At med school, I briefly thought I wanted to be a neurologist, but then quite rapidly realised that involved lots of old people with strokes, and returned to the fold, and have been set on the course of paediatrics since day one, really.
Amazing. Thank you very much, James. So I'll hand over to Vicky now, if Vicky can hear us.
Brilliant. So can everyone hear me? All right.
That's a yes, Vicky. I could hear you.
Oh, yeah. Sorry. Okay. How are we doing with the other connection of the others?
Yeah, I can hear you now.
I can hear you, yeah.
Everything seems to be okay at the moment.
Well, just because whereas I'm sharing the PowerPoint, I can't actually see if everyone's there. So yeah, if you're okay to hear me, then we can move on to some more questions. Then how does that sound?
Sounds good.
Yeah. So kind of moving on from you introducing why you went into pediatrics, could you possibly tell us, some of your best experiences in pediatrics and why, what especially made them good?
Who would you like to start?
Oh yeah, whoever wants to go first. If you want to go first, that'd be brilliant.
Okay. Pediatrics is, I think, a hugely varied speciality. I'm training to be a general pediatrician, which means that I can walk into a consultation room and be seeing anything from a premature baby all the way up to an 18-year-old with mental health issues, and every pathology in between, including gastroenterology, respiratory, neurology, and so general pediatrics has something for everybody, which is one of the things I really love about it. It's one of the last kind of true general specialities, and the patients are just great fun. I normally take 3 gloves out of the box every time I go in to examine a patient, 2 for me and 1 to blow up to draw a smiley face on, and it works every single time, and that's a great thing. And it makes it very easy to do the job, working with kids, because they're just great patients to work with.
Brilliant. And do any of our other panelists have anything to say sort of about their best experience in their career so far?
Can I contribute to this? I think, well, from experience so far, pediatrics is a team sport. You're never alone, and we work with such amazing people.
James, are you able to see that some of the other others on the call don't have their connection on?
I can see Monica and Laura and Rachel and you and the chat.
Oh, okay. For some reason, I can't actually hear Monica, Laura, or Rachel. But
can you hear me now?
Well, yeah, I'm not sure why that's happening.
I could hear Monica.
You can hear Monica. Okay. I'm just going to pass.
People observing hear Monica. Can you write on the chat if you can hear us?
I can hear everyone, yeah. I can hear and see everyone.
Yeah, everybody seems to be hearing.
Okay.
Yes.
I'm going to pass, if Rachel can hear me, because I think the internet connection where I am is just playing up a bit. If you could just carry on asking everyone about their best experiences in pediatrics, I'll try and get my connection to be a bit better, so we just get the flow going a bit.
Sounds good.
Okay.
Yeah, so if Rachel just takes over for a second.
I only wanted to add that to what James has said. Kids are the best patient group ever, and using bubbles in any resource is part of our toolkit. I think when they come in wheezy and really struggling to breathe and all of this, if you have bubbles with you, it's just part of the job. I don't know what is there to not like, to be honest. And the team that you work with, even if we go through difficult times and we see very sick patients, sometimes we see families are really anxious and worried about their child and all of this, and we have difficult conversations. The team around us just makes things easier, I think, and enjoyable, because everyone supports each other. I've not seen anywhere that didn't happen in pediatrics.
when one of the key parts of your team is a person called a play specialist, you know that you're in the right speciality.
Definitely, yeah. And in community, I'm actually being paid to play with kids and to do their developmental assessment. So, you know, what is there not to like? How about you, Laura?
I think I enjoy neonates more than anything else, and the thing that I really enjoy about neonates is that nearly every day you get to see new life being brought into the world, and kind of what could be better than that. Obviously, sometimes it doesn't go quite to plan, and you can get really, really sick babies, but the majority of the time you might do something like dry the baby off or give it a couple of inflation breaths, and then the baby's absolutely fine and you can give them back to the parents and everyone's really happy, and it just brings a little bit of joy to your day every day, and I don't see how anything could be better than that.
Wonderful, thanks so much, guys. I think I've taken away that paediatrics is the only specialty with bubbles, which is a definite plus. Could I ask you guys what a typical day, if there is one, looks like in the jobs that you're in at the moment? So Laura, would you like to start, if that's okay?
Yeah. So it depends whether you are based in the intensive care unit or whether you are based up on the postnatal ward. So on the intensive care unit, you tend to have your handover as per every other place where you might work. And then you'll tend to go and do a ward round in the morning, do your jobs, whatever procedures need doing and things like that, deal with any incoming admissions or any discharges, and then have another ward round in the evening, finish your jobs from the evening ward round, and then hand over to the night team. If you're on the postnatal ward and carrying the delivery bleep, again, you have a handover in the morning, and then you have a huddle with the midwives as well, so that you can all kind of see what the priorities are for the day and how things are going. And then you'll tend to just go and do your jobs for the day, attend deliveries if you need to be there. You might be involved in admitting patients to the intensive care unit, and then hand over in the evening. So it's quite varied in terms of busyness and in terms of what jobs that you might need to do during the day. But it tends to follow that general pattern.
Great, thank you. And James, how about you? Is it similar in intensive care for your job? Or
I think it's very different. So I'm working in one of the regional paediatric intensive care units, which certainly the PICU doctors would argue is a very different kettle of fish to NICU. So my day job is essentially split into two different roles. So I'm either working on the unit, which involves looking after some of the sickest children in our region. So our region covers most of South Wales, Somerset, Devon, Cornwall, and a good chunk of Wessex as well. And essentially any child who is so unwell that they're unable to be cared for locally, transferred to the local PICU, which is us. We also are the regional cardiac surgery centre, so we have a lot of children born with congenital heart disease who wind up with us, and that's our main interaction with the neonatal teams. They often get born in the neonatal unit and then will get transferred to the PICU for their surgical procedure. There's some really, really interesting stuff. You see some of the most acute pathology and some of the sickest children. My interest is high dependency and critical care. That's what I will be doing as part of my general paediatrics job when I become a consultant. The second part of my job is working for the transport team. So I spend probably about 30% of my time with the regional transport team, and that is going and retrieving these very sick children from the district general hospitals and moving them up to the paediatric intensive care. So last week I was in a helicopter moving a child from Truro to Birmingham who needed a liver transplant, and that's part and parcel of the day job that I'm working at the moment. So it sort of ties into the fact that pediatrics is, you can be doing anything any given day of the week, and it keeps it fresh, it keeps it exciting.
Yeah, that's amazing and so varied. And Monica, obviously in the community, things might be a bit different. So what does a general day look like for you?
Yes, it is a bit different. Although as a trainee, most placements, you have to have you have to do some out of hours work as well. So currently I'm in Bradford, and sort of my 9 to 5 is community. I could be starting with a morning clinic where I could see children with developmental delay, or just isolated speech delay, or a syndromic diagnosis, or ex-preterms who have developed cerebral palsy, or anyone who needs neurodevelopmental follow-up longer term. And as part of that clinic, as I said, formal standardized developmental assessments include playing basically with the child. Then I could be, maybe we can have a lunchtime MDT talking about the inner workings of the unit or of the Child Development Center or something like that. And then I could be involved in the afternoon in an autism assessment, for example, which again is being done as part of a multidisciplinary team with a psychologist and a speech and language therapist and a specialist nurse. And if I am covering for a long day, I would be going to the neonatal unit in Bradford and taking over from the day team for the rest of 5 hours of the 12-hour shift, where I would again be involved in all the acute decision making and all the things in the neonatal intensive care unit, which I think is a good mixture in Bradford, where we do both these things, because a lot of the patients, not a lot, but some of the patients from the neonatal unit do need neurodevelopmental follow-up, and it's just an opportunity for us to see what their journey is like on the neonatal unit, and then later on I have a better understanding what they've been through and their families, what they've been through. So I think, yeah, it's a good combination, and it just helps me cover a broader area of the curriculum just by doing both. In my next job in September, I'll be doing pediatric specialty out of hours, which is in Leeds Children's Hospital, where they have all the pediatric specialties. So yeah, I'll be that person going to take handover about all the oncology patients, all the neurology patients that are very sick, and I'm going to be a bit anxious about it. But it's just part of us knowing and getting experience from all these specialties, where some of those patients will end up being followed up in community pediatrics eventually. So yeah, basically.
Wow. Thank you. Again, Monica, that sounds so varied on a day-to-day basis. I think we've captured the full breadth of jobs in pediatrics here, which is wonderful. I was wondering if you guys have anything about your jobs that you find particularly challenging.
Can I start?
Yeah, go for it, Monica.
It's challenging when things don't go as you want them to do. And we do have sometimes children who don't, especially in the acute side of things, who don't respond to what we do. Things really don't, they don't get better, or, they are really, really sick. And we have to have the difficult conversations with families about what the best thing is for them. But I think even that part, as I was saying earlier, it's done as a team, and we're always supporting each other, even if it's difficult, and especially if it's an acute illness, I don't know, a near drowning episodes, and something like that. It's really hard for everyone to process, but I think it's just it's just part of the job, and I find that it makes us a bit more, in a way, a bit more human, and helps me at least understand what people are going through, and trying to help them go through this the best way we can. But I think it's difficult, and oncology patients and patients with a long-term diagnosis, it's a bit more difficult to have those conversations, but I think it's just another communication skill which is part of our job.
Thank you very much, Monica. Sorry, James.
Yeah, sorry, I was going to carry on. You go first, Rachel. I was going to sort of answer a couple of the questions that have come up
of course.
On the chat as well, leading into that. There's been a couple of comments about hours and how much you're expected to be in, even as a consultant, and about dealing with sick, potentially dying children. So I think, I think that there are disadvantages within any speciality that you work in. The on-call rotas that we work on any more onerous, particularly than the medics or the surgeons. I would have said that we all have different crosses to bear. I wouldn't particularly relish working a 20. Some of my surgical colleagues have to. Yes, the training is hard, but I think that you'd struggle to find a speciality that is not difficult in. Consultant, paediatrician, you will probably be in more than your dermatology adult colleagues, and that is purely the nature of the job that we do. If I was a consultant and I had a sick child in the hospital, I would want to be leading that child's care to ensure that child had the best care. That said, so I think that you will find paediatricians will be in the hospital overnight when they're covering an on-call night, more than some other specialities, but equally not as much as, say, accident and emergency doctors. And I think that again comes with the job. Your frequency of on-calls, you'll probably be doing one every 2 or 3 months as a consultant. So it's not a huge burden from that perspective, I don't think. But generally, if you get a call, you're going in, whereas some of the other consultants might not do. In terms of the more difficult and sicker children, I think it's a really challenging area, and people find it very, very emotive. I think particularly at the moment, working in PICU, have the privilege of working with some of these really sick children and their families, and I think it's a huge honour and a huge responsibility to do this well, and to do it properly, and to give families and the children the best possible care that they can have. And in the event that a child does die, which does happen, that we do that to allow them dignity and support the family as much as possible doing it. And I think that there's a huge amount of bravery from the speciality, but also honour in doing that well. And that's one of the great things about my job. And doing that well is really meaningful for me. I hope that sort of answers your question.
Thanks for that, James. That was really insightful. Laura, sorry, did you have anything you wanted to add to that?
No, I think it's been covered by Monica and James. It's always going to be the difficult things, the loss of a child, the difficult conversations that are always going to be the worst part of your job. But as James said, being able to do that situation and handle that situation in the best possible way and having the support of your team around you is what kind of helps you to move on and kind of look at the situation and feel accepting of it and not let it weigh on your mind, so that you can carry on and enjoy the good parts of the job.
And I think the other thing to say is that children dying is really rare. It's really unusual. You know, prior to working in the intensive care unit, where we obviously see the sharp end of the stick, you know, in my entire training, I can number the number of deaths on one hand. And that's not because I'm phenomenal. It's because children generally get better. And that's one of the, again, one of the great things about our job is that children are very easy to fix. Well, most of the time.
And I was just wondering, I think a lot of questions coming through about training pathway. I don't know if anyone could possibly just go through how the training pathway works, and yeah, just give us a whistle-stop tour through that.
So just in terms of peds surgery, you train as a surgeon and then subspecialize in pediatric surgery. For whoever's been asking about that, that's not, you can't get through that through the pediatric route. Laura, did you want to maybe talk a bit about kind of application and early training, and I can talk a bit about the later bit?
Yeah. So obviously, sorry, let me just in the dark. So obviously you finish med school and then you do your foundation training, so F1 and F2, and in F2 you apply for whatever specialty you want to do, hopefully paediatrics. Once you've got your training number, then you are in a run-through program. So if you so choose to stay in general paediatrics, then you don't need to apply for a job at any other time until you become a consultant, which is great. So SHO years, so that's from ST1 to ST3. You kind of get more responsibility as you move up through ST2 and ST3, which is expected because you have more experience. You have exams to complete whilst you are in SHO. So there are 3 theory exams and a clinical exam as well. Obviously, at the moment, it's a little bit different because of Corona, but I think when this all blows over, it will return back to normal. The theory exams encompass kind of basic concepts in paediatrics, theory and science behind it, so a lot of physiology, pharmacology, and the science stuff behind medicine and paediatric medicine, and then applied theory to clinical situations is the last theory exams. And then your clinical one is like an OSCE that you would have in med school, which encompasses kind of history taking, communication skills, and examination, including development examination. And then as you work your way through your SHO years, you're expected to have at least 1 tertiary neonate placement. So you get to work in a specialist neonatal setting so that you've got that experience for when you move into your registrar level, when you get more experience and more responsibility. As regards to the rest of your placements when you are in SHO, you will do some general paediatrics, and then depending on which deanery you're in, they might ask you if you have a preference about where you want to work, and you might get some choice as to what placements you would want to do. My advice from that side of things is to get as broad a knowledge of the different aspects of paediatrics as you can do during this time, unless you have a definitive kind of career path, and then you should try and tailor things towards that career path in that time. But most paediatric SHO placements are pretty similar, unless you're in kind of a real subspeciality. And then hopefully once you've finished ST3, you get to move on to registrar level, which is where Monica and James are, although very senior registrars.
Can I carry on? So in starting at the minute, there is a level 2 part of training and a level 3 part of training. But with the Royal College of Paediatrics is changing the way training will be. From 8 years, there's talk about decreasing that to 7 years in total, and having a level 1 and a level 2 more specialists rather than having 3. But currently, the ST4 and 5, you're doing your core training as a registrar. So you get more responsibility. You are part of, you again, most regions have a mandatory 6 months tertiary neonatal rotation within that. Some general pediatrics, maybe some specialty experience, and definitely community pediatrics experience at the minute. And then at level 3, which is ST 6, 7, and 8, so the last 3 years, you can carry on and get experience in general pediatrics and find a special interest maybe that you want, or you could apply grid training, which is subspecialty separate training, which is what I've done. And there are a lot of subspecialties in pediatrics. I mean, anything you can think of is it. And college also supports special interest modules. So you decide that as a general pediatrician, you want to have an interest in epilepsy, for example. So you go and get 18 months to 2 years, sometimes a bit more, in epilepsy. So you have like an additional expertise in that on top of your general pediatric competencies. And then you become a consultant, you grow up, and you're the most senior person. Anything you want to add to that, James?
No, I don't think so. I mean, I think the thing to reiterate is that when you enter higher level training, you can be a general pediatrician, and within that you can have a special interest, and many people will kind of pursue respiratory, cardiology, gastroenterology, neurology and epilepsy, diabetes, whatever takes their fancy, and there's modules within the RCPCH to pursue those formally. But if you want to do those subspecialities and just that subspeciality, then you go into what's called grid training, and you will become a tertiary specialist in that speciality, and you will only see children with renal disease. So that's the kind of the major difference, and community child health is part of the grid training as well, as is neonatology.
And sort of along the lines of the training pathway, how competitive do you feel that going into pediatrics is? You know, both that starting from F2 to specialty training level, and then throughout your career, like how competitive have you found it?
Competitive?
Yeah, exactly. How difficult do you find it applying for certain jobs, and at different stages? So I'm thinking, between the junior doctor years and your specialty trainings, and then also once you're on the specialty training route.
So paediatrics is and will continue to be a run-through speciality. So once you apply at foundation year and you get a paediatric number, you won't have another interview until consultancy, unless you go for grid training, which is that subspecialty training. These different subspecialties have different competition rates, and I couldn't quote you all of them, but they're more competitive, and that's a national scheme. So wherever you've been training up until that point, you could be, if you get a respiratory grid number, you could be moving to somewhere else in the country to take that up.
Yeah, for example, in community pediatrics, when I applied for grid training, there were 30 national places. Really, I was only applying for the 2 Yorkshire jobs because I didn't think moving my family and around the country was an option for me. The neurodisability, for example, pediatric neurodisability had 8 places. Depends on the subspecialty. There's different numbers. Yeah, it is a bit more competitive if you want to subspecialize. But going into pediatric training at the beginning, ST1, I think I was reading yesterday, it was a 1 to 1.3, I think it is. So it's good, I think. Yeah.
And I think another really important question that I feel a lot of the viewers as well are wondering is, how do you find the work-life balance, you know, as a pediatrician? And maybe that's changed throughout your career as you've obviously taken on different roles. So yeah, what do you think about?
Work-life balance is a pretty intangible thing. It means very different things to different people. Paediatrics is one of the few specialities currently which offers less than full-time training without any other qualification. So you don't need to be a carer, you don't need to be a parent or anything else. You can go less than full-time because you want to go less than full-time with no other reason or rationale for it. So I think emergency medicine and I think possibly GP are offering it as well, but a lot of other specialities don't. So and with the shape of training which will be coming in 2021, there is going to be much more flexibility within the training scheme to stop, take a pause in your training, take out of program placements and pursue other interests and things like that. I think the other thing to say is that work-life balance changes throughout your career. So what I would have described as a work-life balance in my foundation years is very different to what I would describe as a work-life balance now. Speaking to a lot of my colleagues and friends from university, I think where you decide to work has as much impact on that as anything else. I work in Devon, which is what a nice part of the world. So I would say that my work-life balance is pretty good. I've got access to a beach pretty much any day that I want. So there's lots of other decisions that come into it apart from what you're doing as your day job. And I think that's the really important thing to remember. This is a day job, okay? This isn't what defines you as a person. There should be lots of other facets.
Yeah, I agree. I think work-life balance is not, it's an active decision of everyone can sort of change that and make life as good as they want for themselves. I know there will be pressures as part of training, and there will be times when you really need to study for exams, or parts where the demands will be higher. But still, I think there is still scope to create the life that you want. For example, I was full-time until about 2 years ago. I worked full-time, and which was fine, and it worked for me at that point. But then decided, you know what, I want to work 80% and have just a day off a week that I could do anything. I still do a lot of projects related to my training or my work in that day, but equally, if I don't want to, I can do some gardening, or I can just take the dog out. And I live in Yorkshire, so there are plenty of walking paths and plenty of things to see. So yeah, there's I think it's just something that you have to take a bit of control over. It's not all about the job. And I was texting earlier in the chat that, for example, in my next 6 months rotation, I have 7 nights and 7 long days, and the rest are, and I think 2 weekends, and the rest are standard days. So really, this type of rota is not that bad. The neonatal rota, the intensive care rota, maybe they're a bit busier, but still, it's just there is plenty of time for other things.
Thank you very much, Monica, for all those tips. We're just moving into kind of the last few minutes of the webinar at the moment before we'll have to leave for the next session. I was just wondering if anyone has any real top tips for medical students who might be interested in paediatrics to maybe gain some more experience and perhaps prepare for specialty applications.
I think when I was in medical school, I put on the group chat actually, I did things like became involved with the Paediatric Society at my medical school, so helping to organise events and things like that. But just generally looking out for opportunities whereby you can get involved in things, so audit projects, being keen, introducing yourself and making it known that you have an interest in paediatrics, then people might be more thinking, oh, this person's interested, let's see if they want to get involved with this project. And it's all things that kind of go on your CV and on your application. In foundation years, again, letting people know that, hey, I'm interested in paediatrics, this might not be a paediatric job, but they might have consultants whereby that are their friends who might want to kind of invite you along to clinics or let you come and like spend some taster days with them and things like that. So you can always kind of try and be involved in things. When I was on my orthopedic job, I covered the paediatric orthopedic ward, which again, it was a surgical job, but I involved paediatrics as much as I could do at that point. You don't have to have a paediatrics rotation. I think it's a good idea to try and get one, because then you are actually working the job before you're applying for the training.